listening to the Pharmacy Podcast Network.
Hello, and welcome to PTCE's Pharmacy Connect, a podcast focused on continuing education created by pharmacists for pharmacists. PTCE is the leader in pharmacy and managed care education. In these episodes, listeners will be presented with the most recent clinical updates and strategies for implementing into practice. And now, here's our host and founder of the Pharmacy Podcast Network, Todd Urey.
Welcome to this episode, titled Best Practices for Management of Hyperlipidemia, a focus on guidelines and patient adherence. This activity is jointly provided by the University of Connecticut School of Pharmacy Stores and Pharmacy Times Continuing Education, and is supported by an educational grant from Novartis Pharmaceuticals Corporation. The educational objectives for today are as follows. Examine the best practices for optimizing medication adherence and treatment initiation in hypercholesterolemia. Examine best practices for optimizing medication adherence and treatment initiation in hypercholesterolemia management, and to explain patient education and counseling for managing hypercholesterolemia. Hey, welcome back to PTCE Pharmacy Connect. It's been too long. This is an amazing episode with two people. I'm so glad I'm getting to work with Dr. Joe Saseen again. He's back, we were saying, since 2020. It's been too long. This is the best practices for management of hyperlipidemia, a focus on guidelines and patient adherence. That's such an important topic. I'm great to be back. I'm great to have PTCE back on the network. They're leaders in pharmacy managed care education, and these episodes are for our pharmacists, but we encourage physicians to be listening, collaborating, coming up with questions. Engage with PTCE Pharmacy Connect on social media as well. Heavy usage on LinkedIn and also Instagram. Joe Saseen, it's so good to see you and be back on PTCE Pharmacy Connect. How are you?
I'm doing great, Todd. It's great to work with you again also.
And we have a special guest. We have Dr. Mary Catherine Cheeley, and she's Executive Director, Ambulatory Pharmacy Services at Grady Health System from Atlanta, Georgia. It's great to see you, Mary Catherine. How are you?
Yeah, thanks for having me.
All right. So Dr. Joe Saseen, who is a professor and associate dean for clinical affairs at the University of Colorado Anschutz Medical Campus Skaggs School of Pharmacy and Pharmaceutical Sciences in Aurora, Colorado. Dr. Saseen will lead an engaging and practical discussion on hyperlipidemia management, focusing on evidence-based strategies to optimize lipid-lowering therapy. And joining us today, as we just introduced, Dr. Cheeley, and a podcaster to boot. So talk to me about that real quick before we get started.
Yeah, I love it. I love being able to talk to other people in different professions and different specialties that I'm in and learn all the different things that we do as pharmacists, how we collaborate with other providers, or even just the patient experience that we have. I think it makes us better as pharmacists.
Joe, I'm kicking this over to you. You're going to take us through this latest in hyperlipidemia management.
All righty. Thank you, Todd, for passing the baton. I'm really excited to be here again and to talk about something I love, which is lipid management. Just to give you a little bit further insight about my background, as you introduced me, I am a professor and associate dean for clinical affairs at the University of Colorado. We're on the Anschutz Medical Campus, but we're an integrated medical campus where we have School of Medicine, College of Nursing, dental medicine, and other allied health professionals. In my day-to-day duties, I have a lot of academic things that I do, but one thing that I have a passion for is cardiovascular disease, whether it be teaching students or practicing in primary care, managing patients to reduce their cardiovascular risk. Overall, a lot of what I do comes back to lipid management, so I do consider myself one of the lipid nerds, as I know my colleague MK also would align herself with too. It's my passion. As a clinical pharmacist, I really feel that managing hypercholesterolemia can help our patients live longer and live healthier. And I'm just fortunate that I have the ability to do that. As introduced, I'm joined by my dear friend, Dr. Mary Catherine Cheeley. I'll call her MK here forward. She'll be discussing this topic along with me. Collectively, we're going to discuss a whole bunch of different things, including best practices for optimizing medication adherence, treatment initiation, patient education, and counseling for managing hypercholesterolemia. MK, let me just pass it to you to tell us a little bit more about yourself.
Yeah, thank you guys for having me. I love being here. And Joe, I love chatting with you about our shared amazing experiences being lipid nerds. So I am currently the executive director of ambulatory pharmacy at Grady Health System in Atlanta. My purview includes not only our clinical services, but also our community pharmacies, our specialty pharmacies, medication access, and medication adherence. Before I stepped into that role, I was a clinical pharmacist in primary care, where I was gifted lipids by someone who left. And I was like, man, lipids? Like lipids are so interesting. So I definitely drank the lipid juice and totally loved everything about Lipid Clinic. I still, to this day, will go to clinic regardless of what's happening. Thursday mornings are my day to go to my happy place and my sane place to still see patients in clinic. I will never, ever give it up. And that is how you and I met, Joe, through the National Lipid Association. So it has been so great to continue to kind of see our profession grow and then to see within the lipid space how pharmacists can fill that gap as therapeutics have changed dramatically over the last 15 years.
Absolutely never let go of that portion of your job. And I'm so glad that we're colleagues and that we both can help our patients and help our communities by educating and implementing some practice model innovations. For those of you who are listening, you probably noticed that there's 3 Pharmacy Times CE webinars, and they're really excellent. And they cover everything from the basics about hypercholesterolemia to new and emerging therapies for LDL cholesterol and even LPA lowering, and one that focused in on the role of the pharmacist. Some big take-home points for me. The first webinar really did a good job of going over the landscape, why it's important, why lipids will not get old. Cardiovascular disease, #1 killer in the United States for many, many years in a row. It's not cancer, even though cancer is very important. It's cardiovascular disease. So all we can do to mitigate our patients' risk of developing cardiovascular events is really important. And that first webinar really set the stage and went over some of the basics about lipoproteins and really told us that LDL cholesterol remains our #1 target because it's the atherogenic lipoprotein that we focus our attention on, as are some other lipoproteins too. But that, along with risk factor management, really came across loud and clear in that first webinar. The second one was on treatment, in particular, LDL lowering. And I think a big take-home message that I got from that, we have a lot of tools at our disposal. We have statin-based therapy, which has been around for a very long period of time, which is our standard of care. But heck, this is not a boring topic because there's plenty of non-statin add-on agents to lower LDL cholesterol. Proven drugs like ezetimibe, the PCSK9 inhibitors, whether it's inclisiran, which is a newer injection given on a maintenance schedule every 6 months, or a monoclonal antibody. And we even have some newer data with other oral agents like bempedoic acid. So it really is fun. And just getting a glimpse into some of the things that are around the corner, not only for LDL lowering, we'll have some new oral therapies that are PCSK9 blockers. We may have some CETP inhibitors, which are an older drug class, never came to fruition, but maybe, hey, another one might come soon. But also lipoprotein A or Lp(a). You'll hear a lot about that, and there's emerging targets for that. That was discussed in webinar 2. And the third one really talked about, practice implementation. So I'm going to pass it back to you, MK, since you know about webinar quite 3. What were some of your take-home points that you want to share with our audience?
Yeah, so that was the one that I was lucky enough to have a role in. And mine was all talking about the role of the pharmacist within non-statin therapies. We know that statins are king. We know that they're going to be here for a while. But when we get outside of that, we get into kind of where we as pharmacists shine. So making sure that patients are on clinically the right med. We all know to start with statins, but then what's next? We've got so many options now. So which one is clinically the right one for the patient? How do they have access to that? Because while our providers and physicians and APPs are amazing amazing. Nurses do their best. No one is better than a pharmacist at getting patients access to drugs. And we all know that drugs only work if you can take them. And if you can't get them, you can't take them. And then in addition to that, drugs continue to work, but you got to keep swallowing it or injecting it. So making sure that we have adequate medication adherence. And that's what gets us really to that therapeutic objective that we all want of lowering LDL cholesterol. It doesn't work without drugs. You got to make sure that people have access to the things that they need.
Well stated. Yeah, drugs don't work if people don't take them, and we're there to help people. But sort of to drive this home a little bit, I want to share with you a challenging patient that I encountered recently. And this person doesn't come from my particular practice. It's somebody I've consulted on for years. It happens to be a retired pharmacist who I know moderately well. So let me share this patient with you, and I do want to get your insights, MK. So this patient I'm talking about, we'll call this person TJ. He's in his upper 60s, and he's had a long-standing history of hypercholesterolemia. He's also had hypertension and what he calls prediabetes. Also is obese. His BMI is right around 30, though he feels he's fit. He does engage in lifestyle modifications, but he drinks probably about 10 to 20 drinks a week, maybe a little bit more than what we'd like. That's the picture of my patient, TJ. Now, here's why I've interacted with him over the years so frequently. He has had a challenge with taking statin therapy. He was on lipid-lowering therapy, tried what he says more than 3 different statins, everything from daily statins in moderate doses down to lower doses, even intermittent dosing, using rosuvastatin a couple times a week. And he tried that for many years ago when his cholesterol was just high and didn't have as many comorbidities, and he had a problem with tolerability. So he ended up not on lipid-lowering therapy for many years. Well, things changed with TJ. Recently, he experienced an ischemic stroke. It was what he called a minor stroke, so he has a lot of actually residual function, which is great. But his lipid panel during that time of his stroke, his LDL was 162 milligrams per deciliter, his HDL was 38, triglycerides were 215. So he has that metabolic picture along with his diabetes and obesity and not on lipid-lowering therapy. So he's well insured. He has a Medicare supplement, and he decided to go back on rosuvastatin. And he tolerated a small amount, 5 milligrams twice a week, which is off-label. And this provided some benefit. It dropped his LDL down to 125. Now, when I look at TJ, he's asking me for advice. And, this is not the kind of person I'm going to get to go back on a high-intensity statin. It's just not going to happen in this person. So I think about what are his goals of therapy. So I had to remind him, and he knew this pretty well, that per ACC expert consensus decision pathway recommendations, ideally, we really want that LDL cholesterol to be less than 55, and we really want to drop his LDL at least 50%. So we got a lot of room for improvement. So what is evidence-based as far as recommendations thereafter? This is a person who is considered very high risk because of his clinical ASCVD and his other comorbidities, his high-risk conditions. So there would be value in evidence-based and adding ezetimibe, or maybe using a PCSK9 monoclonal antibody, proven therapies on top of maximally tolerated statin background, of which it's very low intensity, better than nothing, but that's what we have. And there may be some consideration to use bempedoic acid, perhaps in combination with something else, since we do have some data on that. It may not reduce his LDL to less than 55, though. So I'll think come to mind some things that this is the kind of patient, because we've had a problem with adherence, that we do need to diligently monitor him, not only for a drop in LDL cholesterol, but just to make sure he's on track and make sure he continues to take whatever we might implement. So as I mentioned, this person's insured with the Medicare supplement plan. He also, as I did not mention, he lives in the mountains, so he's not close to his healthcare system, but he's integrated into a managed care, large, robust health system, which actually has clinical pharmacists that manage medications quite well. And I guess, just to talk a little bit, we use this guy as a framework, but because he came from a health system that had integrated pharmacists, I do want to sort of talk a little bit about these practice models. This person I'm consulting with, but he's not part of my health system. But MK, I know that throughout your career, you really have, developed clinical pharmacy programs and implemented evidence-based treatments. So in your opinion, just share with us, what do you think are some of the best practice models that incorporate sort of a team-based approach to managing chronic illnesses like hypercholesterolemia?
Yeah, so this is one of my favorite topics because I love thinking about the patient being at the center of everything that we do and having this team around them that really gets to practice within their specialty area. So much so that I'm actually wrapping up writing a paper about this, about multidisciplinary care within lipid management. So this is very timely for the discussion. But to me, kind of that multidisciplinary team includes a physician. It does not have to be a cardiologist. I think that is really important for us as pharmacists to understand and to make sure that we're doing our best with lipid care, to know that it doesn't have to be a cardiologist. It can be an internist. It can be an endocrinologist. It could be a women's health provider. Obviously, a clinical pharmacist, I think, is best practice because we can take that patient once the diagnosis has been made. We don't diagnose. I became a pharmacist. I did not want to touch people. So that is outside of what I do. I am going to take that diagnosis and then treat them. That is where we step in to kind of what is happening with this patient. Then we monitor and we adjust from there. So within multiple states, there are collaborative practice agreements where pharmacists have different levels that they can do, either that's independent practice or within consultation with the provider. I think that's huge. One thing that I think is continuing to grow for us in our pharmacy practice is that community pharmacist role. So making sure that we have traditional community pharmacists where we can do, like you mentioned, I developed our medication adherence program at Grady. Those are community pharmacists that are making sure that based on clinical outcomes, or for instance, our A1C's at goal. Nope. Are they overdue for a refill? Let's call that patient. Let's figure out what we can do for that patient. The same is true in lipid management. And then also specialty pharmacists. So you mentioned those monoclonal antibodies or inclisiran. Those are drugs that most insurance companies may consider to be specialty type meds. We know that specialty pharmacy models are really the gold standard. They do that refill coordination. They do benefits investigation. And when patients are integrated within a specialty pharmacy, bonus points if it's within a health system as well, because of that access to everything, making sure that they have access to their meds, they're more likely to actually fill it. That is huge. I also know that in that team-based approach, lipids are super important and meds are great, but you can out-eat a lot of meds. So we need to make sure that we have a registered dietitian nutritionist on board. I think having nursing on board is hugely valuable, making sure that they are that first touch point. When the patient sends in an in-basket message to the provider or they call in, they're talking to a nurse. So we need to make sure that that nurse is integrated into our team, as well as in certain cases, we need a genetic counselor, we need an exercise specialist, we need some of those other patients, other people in there. And one that I think in our paper and in general that we really need to do a better job talking about is behavioral health. So we know that when you have a chronic illness, mental health is very important. Your gentleman that you're talking about is drinking a little too much. And yes, we can do that and we can talk about that, but there is also real mental health conditions that impact our physical health as well. So making sure that we have some type of behavioral health therapist or specialist involved is really, really important. Also making sure that if I was this guy's provider, I would want to make sure that we're making sure he has access to things. So not just access in terms of prior authorization, but you mentioned he lives in a mountain community. Like, we got to get drugs to him. I can't teleport things. That would be great. We would save so much money on shipping costs if we could teleport things, but we cannot right now. So we need to make sure that we can get him his drugs. And that's also something to think about. You mentioned inclisiran, it's every 6 months, but that's in the office. He's got to be able to get there. And so making sure that we have broad pharmacoequity for all of our patients and making sure that we're picking drugs that are evidence-based and really the best thing clinically, and removing those barriers so that they can get access to them, be it PA, transportation, clinical trials, whatever that may be.
Hallelujah. I always love listening to you explain some of this because, it puts it into perspective and gives, credence and credibility to some of the things that I think personally, you've picked up on a lot of the things that are needed for this patient, TJ. And I am concerned about that alcohol ingestion because, just overall looking at this patient, I don't want to look at just the lipid lens and say, I want to fix your LDL. I want to look at you holistically. He's cardiometabolic. I mean, he's at risk for developing diabetes, which could make things a whole bunch worse. The triglycerides and HDL are telling me, yeah, he probably does have need more lifestyle, even though he considers himself relatively fit. But I think some of the things that I also think about is we used to have some taboos in pharmacy. We'd say, and you sort of said it too, and I want to just explore this a little further. We don't diagnose. In reality, we sort of do, right? We identify patients. Yes. Yeah. And even I used to say we never prescribe, but we do prescribe, and states are allowing pharmacists to prescribe. Some of our accrediting requirements are telling us that we need to educate our students about diagnosing and prescribing. So things change, and this is good because we have our traditional roles, but the practice I work in, which is an interprofessional practice, we use a collaborative practice agreement. We call them CBTMs in Colorado, and it allows us to start therapy. Well, we had sort of a project that we worked on with one of our pharmacy residents, a second-year resident, and, for the past 3 months, we've been prospectively looking for business, but business specifically in the lipid space. We're prospectively identifying patients that are in care gaps. So we started with high-risk patients that have secondary prevention status and looking to see is their LDL less than 55, and we're implementing therapy. And it's not always starting a statin. Most of our people are already on a statin. They may not be on enough, but we have to think about these other things like non-statins. So being proactive and using all the tools at our disposal, and a CPA or a collaborative practice agreement really has helped us beyond aggressive because it allows us to do a few things. It allows us to engage in patient care to actually get our patients to their goals to reduce their risk of future disease, but it also allows us to sort of showcase how we can improve the patient care process. And one thing that we really do well, I think our providers, whether they're physicians, nurse practitioners, or PAs, they look at us as being really good with shared decision-making. And shared decision-making can be sort of a scary word because, we don't want to give up control as providers, but let's just face it. You mentioned it, MK. Who's in the center of, let me just ask you, who'd you say was in the center of the patient care team?
The patient themselves.
Patient. Absolutely.
They have to be.
If they're not, nothing's going to happen, right?
Right.
So they're driving their own car. We're just, we're helping them. We're the driver's assist, or we're, that annoying little buzzers that come off that tell you, don't do this unless you want to pass. You're out of the lane. Yeah, yes, absolutely. But we can guide people. We're almost like Google Maps. Which is, a form of artificial intelligence to help us get to where we want to be. So we could be those patient advocates. But I think from a shared decision-making standpoint, one thing that from a sort of a didactic standpoint, the American Heart Association put out a shared decision-making framework recently. It was in 2024. We've heard of shared decision-making for a long time, and we get scared. We can't let the patient decide completely. Well, we need to let the patient have some options and let them decide. We have to give up on that and say, yes, the patient does decide. We just need to inform them. So these 7 elements of shared decision-making, the first one is so important to me. And if I had to scream out one, information sharing is the first part of shared decision-making. And this is what we do. We can share, like with TJ, I can share insights about what his disease is going to progress to if we don't actually do a lot of cardiovascular risk reduction, the truth about some of the medicines, some of the newer ones that have evidence. And if he's concerned with adherence, ones that are more convenient. You mentioned access and pharmacoequity, very important things. So there's a lot that we can share that we have to translate into that patient language. And that's the first element of shared decision-making. There's a few other really important ones. All of them are important. Patient education, which is our way of translating information into specific education on what to do differently, lifestyle-wise or related to medicines. The third is laying out the menu, I call it, and which is really exploring your patient preferences. What are their goals, and tailoring our approach to their goals so that we can actually meet them in the middle and guide them as best we can. Fourth is something that a lot of people don't use, which is really decision support tools. I've had mixed success depending on the person, but for the right person, actually a decision support tool can be quite helpful. Do you use decision support tools in your practice, MK?
It depends on the patient. honestly. Like you and I have been doing this long enough that you can read the patient and you're like, okay, they're going to really understand what a 10-year risk is versus a lifetime risk versus they don't care.
Yeah,
Not they
you're
don't care.
right.
They don't understand it. We need to do a little more education on it.
Absolutely. And that's why I've had mixed success, because some people are
Yeah.
prepared for that. And other people, I work with some highly educated people at the university, and they want to know everything. They look at prediction models, all those things.
Yes.
But actually, the last three parts of this AHA shared decision-making framework are deliberation and discussion, really important. So having your patient digest everything and looking at the pros and cons and discussing that with the patient so that they fully understand. And the key here is if they're really bought into this, they'll comply or adhere with their regimen. Adhere is better than comply. Comply means that derogatory, but adherence is really a partnership, because you want to get to this sixth element, which is really a shared decision-making agreement. What does that mean? It's not just shared decision-making. It's like getting the verbal consent by your patient. That's their buy-in, their commitment to get to their goals through the tools that you're working with them to implement. And then lastly, you don't let it go. Like with my patient TJ, I'm going to have ongoing communication with him, and I have, and review success through monitoring and looking at objective numbers of success. And speaking of this shared decision-making model, remember, information sharing is really, I think, where we can lean in quite a bit, because there's so many medicines to use. But I'll give you a little update on the patient TJ. So he ended up actually going on a PCSK9 monoclonal antibody. That's the one that was preferred by his plan at the time. And after 4 weeks, his LDL went down to 67 milligrams per deciliter. He was pretty pleased with that, encouraged by the reduction. Yeah, it was his provider. It might not be where we want to be, but it's really good. Any comments, MK, from your point as far as like giving patient choices? And we did with TJ to some extent. I still think in the back of my head, he's going to want the injection every 6 months. He'll drive to Denver to get it because of adherence challenges. Right. But tell me a little about what your thoughts are.
Yeah, so 67 is awesome. And a lot of my patients, that is the motivation that they need to keep going. So I think that is huge. I love that you and I are on like opposite sides of the country, but we still practice the same and do the same things. It's like one mind, Joe. We're so good at this. So I think that is huge. I actually had a patient just like this a couple of weeks ago in clinic, and she had multiple strokes. So same kind of picture. And you look at her dispense report. So you look at her history, her fill history. She's on max dose statin, but yet hasn't filled it in 4 months. And she's like, oh no, I take that one. And I'm like, okay, I believe you. I believe that you take what you have. I don't think you have this one. And so that information sharing back and forth, and that like, I'm not accusing you of not taking it. I really think that you want to do the best. You just don't have it. So it's my job to make sure that you get it and make sure that we get you what you need. Even still, so she also has FH and her LDL was well over 250, but neither here nor there. So we knew we were going to have to do something else. We talked through all the options. Same thing. She picked the monoclonal antibody. She was there with her mom. And so her mom is like, okay, I'll inject. I'll make sure that she gets this. We talked about kind of the copay structure between the two. So getting it filled through the pharmacy versus your medical benefit and all those different things. And she was like, okay, I want to try the self-injections at home. I think I'm going to see her in 3 months, and we probably are going to have to switch to inclisiran, more than likely, just because I just don't know that she will be able to consistently get the injections. But she wanted to try it. That was her decision to make. I made sure that we have close enough follow-up. So, hey, we're not going to see you in 6 months. We're going to see you in 2 to 3 because I really need to get a handle on this. And that was the decision that we made together. I hope that she is going to knock it out of the park. Her LDL is going to fall dramatically. That's going to be great. But I do think that there's so many different pieces that we, again, as pharmacists, because we understand that access, because we understand how many patients do you have, Joe, that don't know how to refill their meds? Like they think they need a new prescription every month. Like we're in 2025 and we have people that don't understand basic things that we take for granted. And so that's where, and our providers don't know either because they just keep sending in new prescriptions. That poor pharmacist and the community pharmacy is probably like, you got to be kidding me, man. Like, let's figure this out. But But those type of things I think are really important to wrap up that shared decision making in terms of that review piece. It's not just we made a decision, we're going to set it and forget it. It's we need to come back to it. And that what happened previously, that previous decision, then comes in to inform our next decision. And we start the loop and cycle all over again. We want to make sure that we're not just setting and forgetting, that our patients continue to have that, loop back, be it at the community pharmacy, be it in the specialty space, which again is why I cannot advocate enough for integrated pharmacies within health systems, because that information share is so much easier between them. But yeah, we have the same patients, Joe. I love it.
We do. Practice doesn't change, it just changes settings, but it doesn't change overall a whole bunch.
I'm going to guess my Southern diet is probably a little bit worse than your mountain diet.
Yeah, but we have that mountain beer and a whole bunch of other things up here too. And diabetes escapes nobody. but before we wrap it up, I just really want to talk about sort of a big ticket item, which is really when we're promoting adherence, how do we actually manage some of the costs of medicines? Because some of these great non-statin drugs that work really well and drop LDL significantly can be very costly. And I know you've led a lot of efforts in changing your health system at Grady to manage this. What are some of the things that you can share with us about, your success in increasing affordability to expensive meds? Yeah.
So I think the first thing is to catch it on the front end. Patients lose motivation and patients lose that willingness to kind of go the next step if they get to the pharmacy and see a bill of $500. Even well-to-do patients, they're going to be like, man, I don't know if that's worth it. Like $500. So I think we need to be proactive in it. So at Grady, we used to have a process that was nurse-driven within the clinic. So making sure that we prospectively figure out where these prior auths are coming from. Again, prospectively, when inclisiran came out, making sure that we're giving that patient that cost-sharing information that they have. If it's Medicare, is at 20%. And then going back and doing our legwork first. So having an integrated clinical pharmacist within the clinic, hear me when I say within the four walls of the clinic, to me is best practice, because we can go and talk to that patient and say, hey, look, it's going to take a couple weeks. We are going to call you and let you know what this looks like. Or, hey, I already ran the test claim. I can tell you it's going to be $45 or whatever it may be. And then having an honest conversation about affordability with the patient, because it's not $45 is a lot for my patients. I work in an inner city hospital. That is really expensive, and they will have to forego something else to pay $45. So how do we continue to get that down and have that honest conversation with them, which is a lot easier to have in person than it is over the phone. So then we can pick the right drug. It may be that, hey, the copay for X drug is 3 times what it is for Y drug. And we know that there are several exchange plans that have that. There's certainly things that an on-site clinical pharmacist can do to get the prescribing right in the first place. So that's number one. The second one to me is having a pharmacy-driven medication access department. So at our institution, we have a team of technicians. So one of them, they're called medication access coordinators. They started in the patient assistance space, so specifically with our uninsured patients and getting them access to those manufacturer copay or the manufacturer programs for uninsured patients. Since then, we have realized that it's actually much easier to get an uninsured patient drugs than it is to get insured patients drugs oftentimes. So we created a separate team just doing prior authorizations. We've taken over half the health system so far. Our nurses could not be happier to have us do their prior authorizations for them, but we speak that pharmacy language. We want to make sure that when we're giving that information back to the technician on the insurer side, which then is going to send it for clinical pharmacist review, that we use the right words to increase our ability to actually get that prior auth approved. And then in addition to that, making sure that we have technology support that. We want to make sure that all of those PAs are flagged, or the patients don't leave without knowing that it's going to take a minute to get it approved.
Well, that's awesome. I really appreciate you explaining sort of how you do things and sort of those as you're capturing like some of the final thoughts. I'll just add a few things before we close here. My final thoughts, I think For those of you who are pharmacists listening to today's podcast, recognize that we can make a difference. We can improve care through team-based integrated approaches that really empower our patients through shared decision-making, patient ed, and providing clinical support to facilitate achievement of our therapeutic goals. It has been a pleasure. Dr. Mary Catherine Cheeley, or MK as I call you, thank you for sharing your thoughts today on how we can improve the quality and maximize treatment outcomes for patients with hypercholesterolemia. It's been a pleasure speaking with you. And to our audience, thank you for listening and enjoy the rest of your day.
Thanks for tuning in to the PTCE Pharmacy Connect podcast. Your feedback is important to us. Please share with us your thoughts on this episode and other topics you'd like to learn about. Go to pharmacytimes.org/contact and send us a message.